Good afternoon and welcome everyone. My name is Tina Cordova and I'm the Director of Events for the Elizabeth Dole Foundation. We're excited that you're able to join us for today's Spotlight Series webinar on sleep solutions for veterans and caregivers during the COVID-19 crisis. I'd like to take this moment to thank both Philips and the VA for their sponsorship of this program. Before we get started, I want to mention to all attendees that this is a recorded broadcast. At the end of today's session, we will host a Q&A segment. I encourage you to submit your questions throughout the webinar via the Q&A feature, which can be found in your toolbar at the bottom of the screen. I'd also like to note, while we encourage dialogue, the chat feature will not be monitored. If you'd like your question answered live, I encourage you to use the Q&A box only. A recording and slides from today's webinar will be available and shared on our YouTube channel following the conclusion of today's session. I'd like to introduce today's panel. Joining us from our very own Elizabeth Dole Foundation is CEO Steve Schwab. From the VA, we have joining us Principal Deputy Undersecretary for Health, Steve Lieberman. Our sleep experts today are Will Pigeon, Director of the VA Center for Excellence for Suicide Prevention, and Dr. Daniel Gottlieb, Chief of Sleep Medicine at VA Boston Healthcare System. Finally, our tech expert from Philips Responics is Kevin Dorsack, BMM Channel of Marketing, VA Sleep and Respiratory Care. Thank you all for joining us today, gentlemen. Steve Schwab, why don't you kick it off for us?
My name is Steve Schwab, and I'm the CEO of the Elizabeth Dole Foundation. I want to start by thanking so many of you for the warm greetings and sentiments that you've been sending to Senator Bob Dole. As you may know, he recently was diagnosed with stage 4 lung cancer, but if you know Senator Bob the way I do, he's a fighter, and he's responding to treatment really, really well. But we ask you to please keep him and his amazing wife and caregiver, Senator Elizabeth, in your thoughts and prayers. It's hard to believe that it's been almost 1 year ago to the day when we partnered with the VA and Philips to bring the first in a series of virtual webinars like this, specifically for veterans, caregivers, and their families on high priority topics during the pandemic. Since then, tens of thousands of you have tuned in to view this information and utilize the amazing resources provided by our Spotlight series. Topics have included access to telehealth, mindfulness techniques in managing stress, and most importantly, how to access VA's COVID-19 vaccination program. And I want to thank the VA for doing such a terrific job in delivering those vaccinations across the country. I also want to thank our partners at Philips for their steadfast support and for their continued partnership on the Spotlight series in 2021. I'd also like to make an invitation to all of you. If you have an idea for a topic in this series, please email us at events@elizabethdolefoundation.org. We'd love to hear from you about topics that are of interest to you at this important time. And for all the caregivers who are joining us today, we encourage you to sign up for our Hidden Heroes caregiver community if you've not already done so. Connection, validation, understanding, and support, that's what HHCC is all about. So if you care for a wounded, ill, or injured service member or veteran, please become part of our community and find your tribe by visiting hiddenheroes.org/register. Today's topic is one that is very personal to me and one that's very timely for the military and veteran community: the importance of sleep and sleep solutions for those struggling with a sleep disorder, especially during this pandemic. We all know the benefits of getting a good night's sleep. Being well rested helps you lower your risk for serious health problems such as diabetes and heart disease. It also helps you both mentally and physically, reducing your stress and improving your mood, allowing your body to recharge. But the new normal of COVID-19 has dramatically shifted how we sleep as a nation. And the new routines of working from home, I'm in my home right now, as many of you are, have contributed to many more people than ever before fighting and dealing with a loss of sleep. Early reports from the National Institutes of Health reveal very high rates of clinically significant insomnia across all age groups. along with what we've all been dealing with, more acute stress, anxiety, and depression. Personally, I've been struggling with sleep issues for many years. I thought it was me. I thought it was my mattress. I thought it was my allergies. I thought it was a septal issue with my nasal cavity. I thought it was everything but what it ended up being, sleep apnea, which I was recently diagnosed with. I'm starting a CPAP machine next week. I'm also going to be using a mouth guard for the grinding that I do for my teeth at night. I don't know for how many of you wake up with headaches or being exhausted, but this diagnosis I'm hoping is going to turn a corner for me. So I'm hoping that the information that you learned today will turn a corner for you too. A new study just released by our friends at the University of Texas at San Antonio has found that serious sleep disorders are on the rise in the US military over the past decade. These conditions can affect readiness and cause short and long-term physical and mental health problems for active duty troops, veterans, and families like yours. Specifically, military and veteran caregivers have cited problems with sleep as a top issue for themselves and their families. Well, today you'll be hearing from incredible experts from across the country on interventions and strategies on how you can improve your sleep. And as I conclude, I want to take a moment to thank the incredible public and private partners and sponsors that are with us today, including Cerner, Prudential, Comcast NBC Universal, USAA, Wounded Warrior Project, the American Legion, and of course, Philips, for their incredible support to so many of us and the important organizations we work with. Now I'm going to turn it over to Dr. Steve Lieberman, our partner in this series. He serves as the Principal Deputy Undersecretary for Health at the VA. Dr. Lieberman has served for more than 25 years at VHA, working at the central office in Washington and at VA hospitals in Massachusetts and New Jersey. In his current role, he leads clinical policies and programs for the Veterans Health Administration. Dr. Lieberman, thanks for all your support, and I hand it over to you.
Thank you, Steve, and hello, everyone, and thank you for joining us today. I first want to thank the Elizabeth Dole Foundation for our continued partnership and inviting us to participate in today's webinar. I also want to acknowledge and express my deep gratitude to all those caregivers who have worked tirelessly to ensure the health and safety of the veterans that you have cared for during these challenging times of COVID-19. You should be proud about all that you do to improve the quality of the lives of the veterans that you care for. Additionally, I want to offer my well wishes for the health and well-being of a great American hero, Senator Robert Dole. And I also want to acknowledge my heartfelt appreciation for his amazing caregiver, Senator Elizabeth Dole. In the next few minutes, I will provide a brief update on the current status of COVID-19, including our vaccination efforts, and I will also introduce today's webinar topic of sleep solutions for veterans and caregivers. In healthcare, we are working hard to return to normalcy via our role in the vaccination effort that began in December. As of today, over 50% of American adult citizens have received at least one COVID-19 vaccine, and that number continues to increase each day. Despite our country's efforts to vaccinate, we are still experiencing an upward trend in COVID-19 cases. Part of the reason for this upward trend is because of the more contagious variants of COVID-19 that are out there. And part of it is also because not enough of the population has been vaccinated to date. With that said, we must still be careful even after we have received the vaccine. It is important to continue following CDC guidelines for mask wearing and resuming social gatherings. As a reminder, if you have been vaccinated, CDC recommends only gathering indoors without a mask with others that are fully vaccinated or with one household of unvaccinated people who are not at risk for severe illness. You should still wear a mask, stay 6 feet apart, and avoid crowds in more public places, including medium and large gatherings. As for VA's COVID-19 vaccination efforts, I am excited to share our vaccine eligibility expansion as a result of the Save Lives Act signed by President Biden on March 24th. All veterans are now eligible for a vaccine at VA, even if they are not enrolled for health care. Additionally, spouses and surviving spouses of veterans are eligible, as are recipients of VA's Civilian Health and Medical Program, also known as CHAMP VA. I am also so pleased to share with you some of the details about our enhanced caregiver eligibility under the new Save Lives Act. First, caregivers are eligible regardless of whether their veteran chooses to get vaccinated. They also do not have to be accompanied by their veteran to receive a vaccine. Second, if a veteran has more than one caregiver, all caregivers can receive a vaccine. Third, you do not need to be enrolled in any formal VA caregiver program. Additionally, the Save Lives Act expands eligibility to veteran caregivers to include any family member or friend who provide cares to a veteran. This can include helping a veteran with personal needs like bathing and dressing, or tasks like shopping and transportation. Vaccines under the Save Lives Act may be received at any location wherever a veteran is offered vaccines. This could include being vaccinated as a part of a home-based primary care visit for veterans receiving this type of care where available. As of today, we have delivered at least one vaccine to almost 2.5 million veterans. This is about 42% of enrolled veterans. VA has delivered in excess of 4.5 million vaccines, including first and second doses of vaccines to veterans, employees, and federal partners. To date, 5,823 caregivers who are part of the program of comprehensive assistance for family caregivers have received one or more doses of the vaccine, and about 4,400 caregivers have gotten vaccinated as a part of the Save Lives Act. The bottom line is that for those of you whom have yet to be vaccinated, I encourage each of you to get the vaccine as soon as you can. One of the most important things you can do is to get vaccinated in order to keep you safe and your family safe, including the veteran that you are a caregiver for. I can also not encourage you enough to have the veteran whom you're a caregiver for also get vaccinated. You may be able to convince your veteran better than anyone else. We are unfortunately still experiencing deaths from COVID-19, and getting vaccinated and following CDC's recommendations offer the best protection from the virus. Even if you catch COVID-19, despite being vaccinated, the vaccine makes it much less likely that you will become very sick from COVID-19. As your safety continues to be our top priority, we are following the CDC and FDA's guidance to pause the Johnson & Johnson vaccine due to possible rare side effects. If you had an appointment scheduled for the Johnson & Johnson vaccine, your healthcare facility will notify you of any changes. Of note, it is anticipated that we will have a decision made as soon as tomorrow or over the weekend about the safety of the Johnson & Johnson vaccine moving forward. If you want to receive a vaccine at VA, and we offer right now the Moderna and the Pfizer, with the Johnson & Johnson being on hold, you can sign up in a couple different ways. Number one, go to the website. If you can write this down, it's www.va.gov/COVID vaccine, all one word, no spaces. So that's www.va.gov/COVID vaccine. Or if you didn't get all that down, you can also just Google VA COVID and vaccine, and you will find the link for it. The topic of today's webinar, as you know, is sleep solutions for veterans and caregivers. As a physician that specializes in the respiratory system, I understand about all the problems with sleep that are so common in this country and are stressors for veterans. The past year has certainly brought us new challenges impacting both veterans and caregivers alike. And in a few moments, you will hear from two great VA experts, one in mental health and suicide prevention and one in respiratory medicine, who will dive deeper into the impacts of sleep on overall health and well-being and what you can do to promote better sleep. In closing, while we are in a better place with the pandemic than we were when I've previously spoken to you over the past year, it is not over yet. We must continue to stay positive, prioritize our health and wellness, and lean on one another for support. We must also work together to protect our own health and safety and that of our veterans. So please say yes to receiving the vaccine. I again want to thank all our caregivers for your strength and continued dedication to caring for our nation's veterans every day, and most especially during this difficult past year. I appreciate your time today. It is now my pleasure to turn the presentation over to my colleague, Dr. Pigeon, Director of the VA Center of Excellence for Suicide Prevention. Thank you.
Thank you, Dr. Lieberman. Thanks also Steve Schwab and Tina Cordova and the Elizabeth Dole Foundation. So Craig Smith, Sarah Strum, and others, hey, let's talk about sleep. I have two hats. One is as the director of a VA Suicide Prevention Research Center, and the other is at a university hat that is focused on sleep and on working in sleep research and an insomnia clinic. Next slide, please. So I have 7 minutes to give you my bit on mainly insomnia I'm going to talk about. So I'll give a little preface. Next slide, please, if you can forward the slide. This slide's not advancing. I will just keep talking. So I have 4 main points to make. The first point is that, as everyone knows, sleep disturbance can, okay, we're on point number 1. Sure, let's go right there. Sleep disturbance exacerbates or causes a number of conditions. There's a laundry list of things that sleep can make worse, which is not a surprise to many people listening in today. I think the best encapsulation of that is from a friend of mine named Jojo Jensen, who came up with this quote from, I think, her dad or someone that she grew up with. Without enough sleep, we all become tall 2-year-olds. So isn't that true? So if we're not getting enough sleep, we're just not who we're meant to be or who we're supposed to be. Move on to the next slide, please. The second point I've got to make is that sleep medicine, in general, the field of sleep medicine has some very effective approaches and treatments for the common sleep disorders. There are 59 different sleep disorders. The major ones are listed here. And in today's sessions, we're going to talk about sleep apnea and insomnia primarily. And some of the questions we can also touch a bit on nightmares. I'm going to talk about insomnia. Next slide, please, for the most part. It happens to be the case that the VA, as well as, back one. The VA and the DoD have produced a set of clinical practice guidelines for the treatment of both sleep apnea and insomnia. And what they show, what the recommendations are, essentially mirror what other large bodies have told us. And here's where I'm going to start to get into some recommendations for you all. All of the bodies that have addressed the issue of chronic insomnia came up with the same recommendations over the last decade. And that is, if you're going to treat insomnia in adults, the place to start is actually not with sleep medications, but instead a non-medication approach called cognitive behavioral therapy for insomnia, CBT, little dash and I, cognitive behavioral therapy for insomnia. So I'm going to say CBT-I a lot in the next few minutes. The second recommendation is that we move to sleep medication as a treatment if for some reason CBT-I fails or it's not a good idea for somebody to have CBT-I as their treatment. The reality is the enormous vast majority of patients who have insomnia are actually treated with medications and not with cognitive behavioral therapy for insomnia, even though we all agree that CBT-I should come first. The reason is we don't have enough providers to deliver CBT-I. The VA, it turns out, about a decade ago, recognized this problem and has now trained more providers in delivering this intervention than any other body health system organization on the planet. And it's a very good training. A lot of providers are now able to deliver CBT-I in VAs, in VA medical centers, as well as community-based outpatient clinics across the country. It's still tough to get in because insomnia is such a highly prevalent problem. And I work in the university side as well. On the university side, the wait times for this approach is 6 to 10 times longer even than we might experience in the VA. Next slide, please. Cognitive behavioral therapy for insomnia is a multi-component treatment that is delivered to an individual, can be in a group setting, and I'm going to show you at the end, can be delivered over the app, over apps, or over the web as well. It is comprised of 4 or 5 key facets. The first of those facets, if you look to the extreme right, is really providing some education about sleep, pretty basic stuff, and something that many of you have heard of, sleep hygiene. Now, sleep hygiene is essentially a list of do's and don'ts, things that you've heard before, read before, like, hey, don't drink a pot of coffee before you go to bed. Hey, it's not a good idea to have a large meal before bedtime or to get vigorous activity before bedtime. So things that make sense, but that nonetheless are important if you are somebody that drinks an excessive amount of caffeine up until bedtime or very late into the day, or does things that are just antithetical to good sleep. Addressing sleep hygiene issues are important, but in and of themselves, it's not going to make a huge change for the vast majority of people. Instead, what's important are these 2 other big bubbles. Cognitive therapy, the C portion of CBT-I, focuses on things that many people with insomnia experience, and that is essentially, I can't turn my brain off. I go to bed, I'm wide awake. I'm falling asleep on the couch. I walk up to my bedroom, I turn the light off, and it seems like as soon as I turn my light off, my brain lights up instead, or variations on that theme. Cognitive therapy can begin to address that overactive brain that it seems to turn on at the beginning of the night, or for other people's, it's the middle of the night. I fall asleep fine, but at 3:12 a.m. every day, I wake up and my brain is going. The B bubble, behavioral, is perhaps the most important feature of CBT-I, and it's the thing that most people are not aware of and don't get. There are 2 things at the very top there. Sleep restriction and stimulus control are in and of themselves two individual treatments, and they can be combined in the CBT-I approach. People can do this on their own, but it really helps to do it with somebody that can walk you through it. In the next couple minutes, I'm going to talk a little bit about what sleep restriction and stimulus control are. Next slide. So I think these encapsulate the experience of many people with insomnia. On the left hand, the cartoon where there is somebody has found a way to, on Amazon, purchase an enormous clock that tracks their sleep, but essentially it's tracking their wake time. So have any of you experienced, for instance, laying in bed and wondering, calculating how long you've been awake, but also how long before the alarm goes off, and then coming up with how much sleep you can possibly get at best, and then becoming concerned and worried about the fact that you're not going to get as much sleep as you'd hoped for. Or on the right-hand side, thoughts that go through the brain. These cartoons also encapsulate 2 things that we try to address in CBT-I. So certainly the thinking I mentioned already, but there's something else happening in these cartoons. And that something is quite obvious when I say it. And that is those folks are awake in bed, and they've been awake for a half an hour, an hour and a half, 2 hours, but they're still in bed. One of the most important things you can do if this occurs is to actually remove your wake body from the sleep environment and move it to another room in the house. So if awake for more than 15, 20 minutes, certainly 30 minutes, to move your body to somewhere else in the environment and only return to the bed when you begin to be sleepy again. The difficulty doing CBT-I is that it won't work on the first night. It won't work on the second night, third night. It will work over 1, 2, and 3 weeks. That's a long time to struggle with insomnia when you're doing everything that you're told to do, but still having no results in the initial week or two. Contrast that, however, with, for most people, years of insomnia that they've dealt with. If you can commit to 3 to 4 to 5 weeks of consistent night after night changes in ways of thinking and changes in behaviors, there are very good results from CBT-I. Next slide, please. So I'm going to show you one example here. This is the only data slide that I'll show you of what happens when someone does that. This is a research study that we did with veterans who had insomnia. They not only had insomnia, these were veterans who also had major depression or PTSD and were actually experiencing thoughts of suicidal ideation or having suicidal thoughts. We delivered CBT-I, this intervention, over 4 weeks. And what the slide shows, the blue bars are the percent reduction in the severity of insomnia on the leftmost, compared to very little change when we do nothing for sleep. So that makes sense that we have a great improvement on sleep or insomnia symptoms, and the red bar, hardly any improvement if we don't do anything. But it also turns out that when we improve sleep in this manner, not only does sleep improve, but things like depression severity improve and the intensity of suicidal thoughts decrease as well. And this is only by treating sleep. So it's not that we also had a depression treatment or a suicide prevention treatment. We treated insomnia only, 4 sessions, once a week for 4 weeks, and had a pretty dramatic increase in positive mood for these veterans engaged in the study. I wanted to show that there's some science behind this. Finally, last slide. I will address many questions that folks had about how to engage in these kinds of behaviors. But one main message that I want to impart is back to the primary approach for treating insomnia is this cognitive behavioral therapy for insomnia. There were many questions about, are there non-medication approaches? Yes, you have to find it though. You can ask for it. So a primary care provider can give you a referral to the sleep medicine service. You can look up the sleep medicine service yourself. And these providers in the VA anyhow, who provide this are in different places. They might be embedded in primary care. What you're looking at now on the slide are 3 different web or app-based approaches that deliver CBT-I. So if you're the kind of person who thinks you can do this yourself, there are DIY, do-it-yourself approaches. CBT-I Coach is listed here as a therapy add-on. So it's an app, it's free, and it's downloadable on your phone, and it provides information on CBT-I if you're doing the CBT-I with somebody else. So it's a coach for you to help with the therapy that you might be doing. The one in the middle, Insomnia Coach, is completely do-it-yourself. It takes you through the entire CBT-I program. And then finally, to the far right, this is a web-based platform. If you go back to it, please. A web-based platform called Path to Better Sleep. At the very bottom, there's a link to that. It's a VA product. All of these are VA and/or VA and DoD combined products that can deliver CBT-I if you don't have ready access to a therapist that can do that. And again, I'm looking forward to address some of those specific questions that folks have. Thank you.
Okay, hello. I'm Dan Gottlieb from the Boston VA, and I'm going to just share my screen here and dive right in. Let's see. All right. I'll trust that those slides are showing, or I would hear from someone. I'm going to start by talking about what obstructive sleep apnea is and why it happens. So our airway from the back of the nose down to the vocal cords is a floppy tube. And so that when we breathe in, the pressure that sucks air into our lungs wants to suck the airway closed. Now, usually that doesn't happen because there are muscles in the airway that contract to stiffen it. But when we go to sleep, those muscles don't work as effectively. And in some people, that allows the airway to collapse. When there's a partial collapse of the airway, there's a reduction in airflow, usually accompanied by snoring, and we call that a hypopnea. When there's complete collapse of the airway, there's no flow at all, and we call that an apnea. It's considered normal for this to happen about 5 times an hour. When it happens more than that, we call it obstructive sleep apnea. How do I know if I have sleep apnea? Well, some of the most important risk factors for sleep apnea are overweight and obesity, so that people who are overweight are about twice as likely to have sleep apnea as people who are not. And obesity can be associated with as much as a 4 to 10-fold increased risk of sleep apnea. But that said, even people who are thin can have sleep apnea. Men are about twice as likely to have sleep apnea as women. But again, women certainly are not uncommonly can have sleep apnea. And then the risk of sleep apnea increases with advancing age. The most common signs of sleep apnea are loud, and particularly loud, irregular snoring. Less often people report that they've been observed to stop breathing at night, and that certainly is very suggestive of sleep apnea. And as far as symptoms, the most common symptom of sleep apnea is unrefreshing sleep with excessive sleepiness or fatigue, regardless of how much time a person has slept at night. Less often people report that they may wake up with a choking or a gasping sensation, but most often when sleep apnea awakens someone, they're not aware of what awakened them because the obstruction goes away as soon as they wake up. Headaches that occur on awakening and go away within an hour or two of awakening is also a common symptom of sleep apnea. Sometimes heartburn that occurs primarily at night can reflect sleep apnea, as can frequent need to urinate at night without other cause, such as an enlarged prostate. Now, sleep apnea is a very common condition. In the general United States population of adults, sleep apnea, at least mild sleep apnea, is present in about 1/3 of men and 1 in 6 women. And about 1/3 of those have moderate to severe sleep apnea. But it's worth noting that only about 20% of people with sleep apnea have actually had their sleep apnea diagnosed. Now, sleep apnea does appear to be somewhat common, more common in the veteran population, but sleep apnea is also more likely to be diagnosed in veterans, with about 1 in 5 veterans actually carrying a diagnosis of obstructive sleep apnea. Let's see. Okay, so what are the consequences of having sleep apnea that's not treated? Well, the short-term consequences are very clear. Excessive sleepiness or fatigue, associated increased risk of motor vehicle crashes, decreased quality of life, and also patients will commonly complain of cognitive deficits, such as impaired short-term memory, and these things will, in most cases, improve with treatment of the sleep apnea. Sleep apnea is also recognized as a cause of high blood pressure, and particularly of resistant hypertension or high blood pressure that doesn't respond to multiple medications. Sleep apnea is also associated with a greater risk of diabetes, as well as with heart disease, including heart arrhythmias, particularly atrial fibrillation, and also associated with an increased risk of stroke, although it's not entirely clear that these are caused by the sleep apnea and not by the things such as overweight and obesity that cause sleep apnea. And at this point, we don't know whether treating the sleep apnea will reduce the risk of those conditions. It used to be fairly complicated to diagnose sleep apnea. It required coming into a sleep laboratory for testing overnight. Here's the patient on one side of the partition, and on the other is a sleep physician here with all the apparatus that the patient is hooked up to, including these amplifiers and a strip chart recorder. Of course, nowadays, all that paraphernalia can fit in your pocket. And it's enabled us to move sleep apnea diagnosis, for the most part, out of the sleep lab and into the home. This slide shows a fairly typical setup with the sleep monitor, the actual recording device here, belts around the chest and abdomen to measure effort to breathe, a probe on the upper lip or in the nostrils to measure airflow, and a probe on the finger to measure blood oxygen level. And we have a sleep technologist instruct the patient in how to use that device. They wear it overnight for a night in the comfort of their own home. They drop it in a prepaid mailer and send it back to us. And the success rate of those studies is about 90%. Now, with the onset of the coronavirus pandemic, when we were no longer seeing patients face to face, we recorded a video and instructed patients over the phone, gave them a link to the video, and mailed the device to them. And this has been almost as effective as the face-to-face setups. And we now do this really entirely by phone and mail, and made it really much more convenient for the patient. Now, a recent VA Health Analytics and Information Group report that we put together in 2019 found that sleep services were provided in 98% of VA medical centers. Almost 80% of them offered home sleep apnea testing. About 2/3 offered in-laboratory sleep testing, which is still needed for disorders other than sleep apnea and in some cases of sleep apnea. Now, of course, diagnosing sleep apnea wouldn't be very valuable if we couldn't treat it, but fortunately, sleep apnea is a very treatable condition by physically removing the obstruction. And there are three main approaches that we take to doing this. Behavioral changes, which are the main, which should be recommended for everyone, but they may be the sole therapy that's needed for people who are not symptomatic from their sleep apnea, have minimal symptoms or mild sleep apnea. And these behavioral measures include weight loss. We know that during the coronavirus pandemic, about 25% of people reported gaining more than 5 pounds. And on average, those people who gained weight gained about 15 pounds. Losing that weight may be enough to get rid of sleep apnea that developed with that weight gain. Aerobic exercise certainly helps with weight loss, but it has also been shown to reduce the severity of sleep apnea even independent of weight loss. Sleep apnea is typically worse when sleeping on your back, and so avoidance of supine sleep, that is sleeping on the side or prone position, may be enough to treat sleep apnea in some patients. And then avoidance of alcohol, which will tend to make sleep apnea worse when it's in your system. Now, for people who have severe sleep apnea or very symptomatic sleep apnea, the mainstay of therapy are medical devices, of which the most common is continuous positive airway pressure, which I'll talk about in a moment. And then there are surgical options as well. So let's see. So CPAP, or continuous positive airway pressure, many of you may be familiar with. Basically, this is a device about the size of a small shoebox that applies pressure to the airway. It's got a powerful fan, some fancy electronics. It applies pressure to the airway through a mask that's worn over the nose or over the nose and mouth. And that pressure acts as a splint to hold the airway open. And it's extremely effective at keeping the airway open if you're able to use it. However, there are people who have trouble with using CPAP. I think that this is a problem that many people have the sense that, well, nobody wears their CPAP. And in fact, that's not the case. And there have been a lot of improvements in CPAP over the 36 years now, I think, since it was first introduced commercially. Many of those have been made by Philips, Respironics, and other major CPAP device manufacturers that have made the devices smaller, quieter, delivering pressure in a more comfortable manner. There are a couple of innovations in CPAP that I think are worth mentioning. One is self-adjusting or auto-titrating CPAP devices, which monitor a patient's breathing and can adjust the pressure as needed to control the sleep apnea. And this is great because it allows the lowest necessary pressure to be applied, which makes the device more comfortable. But also it allows us to initiate therapy without requiring a patient to come in overnight to the sleep laboratory to adjust the pressures. Another is the ability to wirelessly monitor what the CPAP devices are doing. So it allows us to identify when there are mask leaks, it allows to identify whether the sleep apnea is adequately treated, or whether a patient is using the CPAP. And that allows us to intervene early, identify problems that a patient is having with the CPAP, and respond to those. And with this type of support, about 2/3 of patients are able to use CPAP effectively. Now, what about the third that can't use CPAP? Well, as I mentioned, there are other medical devices. Oral appliances are one of the most common. These are devices that are worn in the mouth. They use the teeth to hold the jaw forward, and because the tongue is attached to the tip of the chin here, that pulls the tongue forward, makes more space in the back of the airway, and can improve sleep apnea, particularly in people with milder sleep apnea, or people who are less overweight. It's more likely to be effective. And it's important to know that these oral appliances, although they're made by a dentist, are authorized for treatment of sleep apnea, even for veterans who are not eligible for VA dental services. And then there are a number of surgical treatments that can be used to treat sleep apnea. These fall into three main categories. One is modification of soft tissues of the upper airway, such as removing the uvula, that thing that hangs down in the back of your throat, and some of the muscle that it's attached to. That can be effective for some patients. Skeletal modifications of the upper airway that advance the jaw forward can be extremely effective, although it's a fairly involved surgery, and we don't do it that often, but it can be quite effective. And then the new kid on the block that you may have heard of, certainly I have patients every week who ask me about it. This is essentially, it's called hypoglossal nerve stimulation. It's essentially a pacemaker for the airways, for the muscles of the upper airway that hold the airway open. And what this shows is the pacemaker has a sensing lead that tells when a person's taking a breath, and that triggers stimulation of a nerve in the neck that causes the tongue to protrude somewhat. And that can be quite effective in a select but relatively small group of patients with sleep apnea. So to summarize, sleep apnea is very common, particularly in the veteran population. It's relatively easy to diagnose, and the resources for diagnosing it are available in most VA medical centers. Treatment will lead to improved sleep quality, less daytime sleepiness and fatigue, lower risk of motor vehicle crashes. It can reduce blood pressure, and it may lead to a reduction in the risk of stroke or heart attack. And one thing that I want to mention also is that I'm asked a lot about sleep apnea and post-traumatic stress disorder. And there's not any good evidence that obstructive sleep apnea causes PTSD or that PTSD causes sleep apnea. However, a number of studies have shown that treatment of sleep apnea may reduce PTSD symptoms such as nightmares and may lead to improved response to other therapies for PTSD. So I'll leave it there, just mentioning that there is a VA website that has a lot of resources regarding sleep apnea, and the web link is there, but I think if you simply Google VA and VA training in sleep apnea, it will bring you to this page. Okay. So I'm going to stop sharing and turn the floor back over.
Hey, good afternoon, everyone. Very excited to be here on this very important topic. I'm here to wrap things up and talk about the importance of OSA innovations for veterans. Next slide. Just a little disclaimer. We can go on to the next slide. So a lot of you may have a family or a friend that has CPAP treatment or has sleep apnea. So what comes to your mind when you think of somebody with sleep apnea? Not sure quite this was what you had envisioned, but people have many different thoughts when they think about OSA treatment, sleep apnea, or CPAPs. Next slide, please. So what does it really mean? This may be familiar with in-lab testing. This is something that you would see very important for people with much higher degrees of sleep apnea. You also might think of the bigger, louder boxes that were in the past, right? Things that you may have seen from your father or grandfather. You also might think of these big obstructive looking masks, right? That sometimes people are very fearful of when you talk about sleep apnea treatment. But what if sleep apnea treatment was more like this? We discussed a little bit about home sleep testing, something that's a little bit less invasive, something that puts you in your own home that you could test and feel more comfortable with. The devices are getting smaller, quieter, less medical looking, being able to be portable and you can travel with. And obviously the mask, right? That's the most intimate part of the sleep therapy treatment. They become less and less obstructive, lighter weight, more comfortable. That's the thing that your face touches each and every night. So at Philips Innovation Pipeline and areas of exploration, we're always looking for ways to make the patient veteran experience better. We try to always improve the patient experience of care, including the quality and satisfaction. We're also looking to help with better health outcomes, improving the health of patients and populations. And we also look to help the staff experience, whether that's at the VA or other hospitals, by making and improving the work life of health professionals. So obviously our goal is to get more and more veterans, more and more people adjusted to sleep therapy. So when we innovate sleep solutions, we help to improve the patient veteran health outcomes. We try to increase the therapy usage. We try to help increase the patient compliance, staying on the treatment for a long time. We attempt to design products to be smaller, quieter, and less medical looking. We design the tools to help patients select the best mask fit. We make masks that are more comfortable, lighter, and less obstructive. We also try to provide the services to help patients through this transition period. We also try to create patient interaction tools to help motivate, track, and troubleshoot. And some of these things I'll now talk about a little bit more in depth. One of the greatest things that's come out in the last couple of years in mask innovation is a mask selector. These are things, especially in a COVID period, that have lent itself to really allowing people to get masks selected, whether at home or in a patient or doctor's office. We have two different varieties. There's a 2D scanner that you can use your smartphone for, and a 3D scanner that's more for an iPad in a physician's office or in your sleep lab. And what we're really seeing is that patients needed only one mask at the initial setup with these mask selectors. So this innovation has really helped with the selection of process of masks to help patients feel more comfortable that the right mask is chosen for them at the very beginning. Another thing we like to talk about is a thing that we call Dream Mapper. This is digital support for behavior change. At Philips, we believe that behavior change is a key to patient success with therapy adherence. Not only try to make the devices smaller and quieter, and we try to make the masks lighter and less obstructive, we found out that actually when patients are involved in their healthcare, these behavioral changes also help in their acclimation or transition to sleep therapy. So what type of changes behavior? We look at personal relevance, anatomy, help to empower the patient, help with the urgency, and also help with social support. So our motivational behavior support helps change the patient portal tools, goal setting, it helps motivate, and it really gives you some personalized vetting. So now you have a greater stake in your health treatment. We've seen that 58% more people reported using their PAP therapy every night, and that we have about a 283% increase with a higher success rate was achieved for patients struggling with adherence to sleep therapy. So again, this behavior modification along with the device and the mask really has lended itself to better compliance with our patients. And not only about products, right? We're about services as well. We try to really figure out how else can we help the VA and VA staff help treat you, the veterans. So we also have these services to help increase the veteran utilization and follow up with remote monitoring. So these types of services that we offer to help take off some of the extra stress and strain placed on a lot of these type of operations. So these type of services can really help the VA enters the new patient. It really helps track the patient. We provide sleep coaches that actually follow up and call the patients and the veterans to make sure that they're acclimating with the device, that the device settings are set properly, that their mask fit properly. We also then intervene with the veterans who struggle that are escalated to a licensed respiratory therapist to give them additional support. It's all about the support and treating these problems and situations early on in the adoption of therapy that really lends itself to success over the long term. So patients receive personalized one-on-one care through live call coaching. We also have seen a 24% average relative increase in a 90-day compliance rate, which is so important. We don't want patients or veterans just to be on the device for a little bit. We really want them to see the benefits for a long term. And we've really seen that 79.5% of all of these patients meet the 90-day CMS compliance guidelines. So again, the addition of the products themselves and the solutions and the services have really lent themselves to a better opportunity to help people get acclimated with their sleep therapy. And our goal is to have everybody wake up to a better sleep by getting the help you need.
So much, Kevin. Thank you so much, gentlemen, everyone, for being here and participating in our series today. We're going to start our Q&A session now. I'm going to kick it off with our first question, which is for Dr. Pigeon. Dr. Pigeon, I also want to remind everyone that this is recorded and we will be making this video available on our YouTube channel post the event. So Dr. Pigeon, I use a Fitbit to help monitor my sleep, and it frequently tells me I'm not having a good night's sleep. What should I do? In general, how reliable are these devices? Apple Watch, Oura Ring, Fitbit, etc. Is there one you recommend over the other?
I don't recommend any specific device. They tend to be okay and not great. I wouldn't use one myself. If I were using one and it was telling me I had poor sleep, but I felt fine, I wouldn't believe it. If it told me I had poor sleep and I didn't feel very good, I'd go, I think it's right. I'd like to mention, because there were questions about the apps that I did mention, CBT-I Coach and Insomnia Coach. On the slides, which will be made available, there's information on finding them, but they're available both at Apple, the Apple Store, as well as Google Play.
Thank you so much. Our next question is for Dan. Dan, we use a white noise machine as a sleep aid. Are these safe to use? How loud should we be keeping these machines?
So the white noise machines are generally quite safe to use, even over the long term. Ideally, you want them to be just loud enough to, to drown out ambient noise. For children, it's recommended that they not be higher than 50 decibels. In adults, probably so long as it's 70 decibels or lower, that should be safe.
Awesome, thank you. Our next question is for Dan and Will. I don't do well on medicines. Are there any natural things and supplements I can use to help with sleep or depression or anxiety? We also got some questions about melatonin. Folks are wondering if this is safe to take daily.
So besides non-medication approaches like the one I mentioned, CBT-I, there are some things that can help a little bit. So over-the-counter Benadryl taken a couple nights a week is not bad. I'm not a prescriber, so Dan should chime in. With respect to melatonin, I tend to steer people away from melatonin. It hasn't been shown to be a very good aid for insomnia. One. Secondly, it's available in doses much higher than is needed. So if you're going to take it, I would suggest at 5 milligrams below or lower. 2.5 milligrams is fine, which often means you have to cut a 5 milligram in half. If melatonin is going to be helpful, it's for people who have a circadian rhythm disorder. Their sleep schedule is way off. Dan should address this as well, though.
Yeah, I would say that certainly melatonin has been clearly shown to be helpful for people who do have a circadian rhythm disorder, where their body isn't ready to go to sleep until hours after they need to go to sleep. And that can often be dealt with behaviorally, but melatonin taken not right at bedtime, but actually several hours before bedtime can be helpful. And they're very low doses, as low as 1 milligram or less has been shown to be valuable for that effect. I think melatonin is a mild sedative, and it's generally has a reasonably good side effect profile. I think that for people who have anxiety that keeps them up at night, I have certainly not found melatonin to be particularly helpful. Although it may not be harmful. One thing to know is that for the over-the-counter melatonin, most of them don't have a USP label. They're very poorly regulated as to how much melatonin is actually in them, and it may be anywhere from none to much more than the label says. So I think that if you're going to use it, the pills that we have in our formulary are 3 milligram tablets, and that's in line with the dosage that you had indicated. So in terms of natural things, I don't know that a lot of people will and I include myself among them, will have a cup of sleepy time tea in the evening. Preferably not too close to bedtime because you don't want to have to get up to urinate at night. But I think that it's not so much what's in it as the routine. And I think having a regular routine that relaxes you and tells your body and your mind that it's getting on time for sleep can be very helpful, regardless of the specific ingredient that's in it.
Thank you. That's really insightful. Our next question is for Dan. Dan, what are good alternative treatments for sleep apnea if your CPAP isn't working?
Okay, so I think I went over that some of my talk, but the key things are, one, the behavioral things, so that weight loss, regular physical activity, avoiding alcohol, avoiding supine sleep can be helpful for many patients. For people who have positional sleep apnea but have trouble staying off their back at night, there are a number of pillows designed for this, or one that we like is a belt that goes around the abdomen and has a foam cushion in the back that isn't painful if you roll onto it, but it makes it hard to stay on your back. So things like that can be helpful. Beyond that, I think that for people who have teeth and gums that are in good condition, if they're not able to tolerate CPAP despite working with different masks, dealing with the variety of things that can make CPAP difficult to use, many of which we can address. Dryness, discomfort from the mask, mask leaks, even anxiety from the mask, with awake desensitization, having someone put the mask on for a brief period of time while they're awake and gradually increasing that time each day, that can desensitize them to the anxiety the mask can cause. But that said, when we can't do that, oral appliances, I think, are often a good next choice for people who are not able to tolerate CPAP. And then beyond that, I think that it's worth considering the surgical options and consulting with a surgeon who really is very experienced in that area, who can help to decide whether any of those approaches are likely to be effective for a given patient. Unfortunately, at this point, there are no medications that are shown to be effective for treating sleep apnea. There are actually a couple on the horizon, and it may be that 4 years from now we'll have a pill that we can offer for sleep apnea, but I'm not convinced that will be effective other than in milder sleep apnea. Exercise, if I didn't mention it, helps with sleep apnea, both through weight loss, but also through effects that we don't really understand that are independent of weight loss. So those are the key things that are available for treating sleep apnea.
Thank you so much. I know we're nearing time, but I'm going to try and squeeze in a couple more questions before we go. Will, what is the VA's opinion on the use of cannabis or CBD products to support sleep?
I don't know about VA's opinion specifically, but it's whenever anything new comes along, it takes a while to be adopted. At this point, I don't think there's science enough science to say, yes, it's a great aid. My own personal belief is that it could be helpful for some people, but it's not going to be as helpful, I don't think, personal opinion, as the medications that we already have, and not as effective as the CBT-I treatment that I was harping on earlier. I'm gonna say one thing, unrelated, but this has come up. I want to make clear that it's very normal to wake up several times during the night. Many people with insomnia think, like, oh my God, I woke up. It's a disaster because I woke up. We wake up normally 3, 4, 5 times a night. That's perfectly normal. So don't freak out if you're waking up. Freaking out comes if you wake up, of course, and then are awake for a long time. So wanted to make that point.
That's a really great point. Thank you. Next question. If I have concerns about having sleep apnea, do I just tell my VA doctor at my next visit that I would request a sleep study?
I think that's a perfectly reasonable approach. If you have concerns about your sleep, whether it's sleep apnea or other sleep problems, I would discuss it with your primary care provider, and they should be able to refer to a sleep provider within the VA. As I said, the vast majority of VAs do have sleep providers, and when they don't, they should be able to refer for an evaluation via community care if your symptoms suggest sleep apnea.
Thank you. Dr. Gottlieb, this next question is also for you. Do you all have any advice for helping children with their sleep? After this last year, this has been a huge challenge for my family. We've tried the typical things, but still need help.
Okay, well, I'm not sure what's involved in the typical things, but the things that I say may sound like common sense. Having regular routines, regular bedtime routine, depending on the age of the kid, maybe that's a bedtime story, after brushing teeth and so forth. But keeping a regular bedtime, regular rise time, as well as keeping other things in the daily environment as regular as possible. So meals at roughly regular times can be helpful. One thing that I can't overstate the importance of, particularly in this setting where people are spending more time at home, more time on screens, both recreationally and for school, is that it's been clearly demonstrated that use of that screen time, particularly in the period shortly before bed, can lead to difficulty sleeping, and so we recommend avoiding screens within the last couple of hours, especially the last hour before going to sleep, and things like phones and tablets tend to be worse in this regard than television, but probably better to read a book than to use any type of electronics in that final period before going to bed.
Great. Kevin, this next question is for you. I feel like I've tried all the new technologies out there to help with sleep. Given that Philips is a leader, what innovations are you most excited about that you think will transform sleep over the next few years?
Thanks for the question. I think what we always do, we strive for company, is try to make that patient and veteran experience better, more comfortable. So a lot of our innovations really are centered around the device, the mask experience, because we find that making the patient more comfortable gets them acclimated easier. So with that mask selector that I talked about earlier, it's one of those forms of innovation where now either during COVID, when you're working with a patient or veteran remotely from their home, they can more or less use an application on their smartphone, a 2D application, or an application within the facility itself, which is a little bit more precise on a 3D. But what this really does is give that patient or veteran a little bit more confidence that the mask that's going to be selected for them is one that's going to fit better, the one that's a little bit more personalized or customized for their need. And I think that gives them that added boost of confidence, like anything, that when you feel that something was designed for you or put in place, that it's going to work a little bit more efficiently for you. So we see good things from those types of innovations.
Thanks so much, Kevin. Next, we are going to do 3 more questions. I promise we're wrapping up, but we're getting just great feedback and responses. What is some advice for going back to sleep after nightmares?
That's a great question. Removing yourself from the bedroom, certainly if the nightmare experience, you wake up from it and you're fairly aroused, and because it's been an intense experience, removing yourself from the bedroom, going to the living room, another room, and calming down a little bit, whatever that means for you. That could be reading, that could be TV, that could be breathing, if you know some breathing exercises. So that's one. In the moment, if the nightmare is incredibly intense and you're in that in-between state of not being sure if it's real or if it's a nightmare, taking a moment to ground yourself. Some people will know that language. So feel the bed under you, realize, yeah, I'm in bed, I'm not in the nightmare. Look around the room, realize you're in the room, and then remove yourself from the room. And as I mentioned with insomnia, and then waiting until there's at least a little sleepiness, or there's been not five, you wouldn't remove yourself for 5 minutes, more like 30 minutes, 60 minutes, and then returning to bed. Doesn't do a great job for sleep that night, but it prevents you from being awake for 3 hours potentially.
Thank you so much, Dr. Pigeon.
Hey, Tina, I'm going to let folks know, yes, prazosin, there were some questions about it, can be used for nightmares, prazosin, prescription medication that works very well for nightmares.
Thank you. I'm sure that's going to help quite a few people. Dr. Pigeon, also, I have a question here for you. I'm a veteran that struggles to get only 2 to 3 hours of sleep each night. What is something I can do to overcome my insomnia? Yeah, so I'm sorry for folks to keep going back to the, sounds like for someone with that level of insomnia, sleep disturbance, getting in front of a sleep specialist and getting a full evaluation. It could be that it's not uncommon for people to have insomnia as well as sleep apnea. So there may be more than one sleep thing going on, but this means getting in front of somebody who's a sleep medicine service folk to evaluate that. And then for the insomnia, I would start with the CBT for insomnia, see how that goes. Thank you so much. All right, we're going to do our final question here, and I'm going to open this up to our entire panel. Can you each talk a little bit about a positive pre-sleep ritual that you use or that you've encountered in your work that you would recommend? Dr. Pigeon, you want to start us off? Sure. So 2 things. One, I would say it shouldn't be a 5-minute ritual. It should be a 30-minute ritual. So longer is better so that there's more wind down time. For many people, reading in a low light environment, in a comfy chair, without the TV on, without your phone on, so the other distractions are removed, is a good option, but there are several others.
If I could just piggyback on Dr. Pigeon's or Will's advice just now. I told you I've been dealing with my own sleep apnea issues. Well, I've started a ritual just like that. At 9 o'clock at night, I stop watching television, especially cable news, settles me down. I've removed the phone from next to my bed. I've also utilized an app called Calm, C-A-L-M, which has a 10-minute daily meditation and an evening pre-sleep meditation for folks who are interested, C-A-L-M. And removing the phone and reading in low light have been a game changer for me. Dr. Gottlieb?
Yeah, well, I also try to read for about 15 or 20 minutes, usually is all it takes before my eyes are shutting. But reading, and as I mentioned, I have a cup of warm, non-caffeinated tea to also help relax and set the stage for me.
Kevin?
I think it's remove the electronics, right? Remove the phone, the iPad, the TVs from your room, the things that distract you from not getting a restful sleep. Falling asleep with the TV probably isn't a good idea because eventually it'll wake you back up and you'll have to make adjustments there. So I think it's the electronic aspect of life.
Okay. Those are really great, really great points and tips for everyone. And Steve, I actually use that Calm app too. It's great. So that's a really great tip. I want to thank everyone for attending and to all of our panelists for making the time to be with us today. I apologize that we can't answer all of your questions. We had just an unprecedented number submitted, So thank you all for the interest and the participation in today's program. I would also like to again thank our sponsors and partners for this program, Phillips and the Veterans Administration. If you enjoyed today's webinar, I encourage you to check out our YouTube page for past webinars on helpful topics like telehealth, rural health, and whole health. And that's also where you can find this program probably starting tomorrow. The Elizabeth Dole Foundation is also excited to announce our second annual Military Kids Have Talent program. It launches next week on April 28th. So please be on the lookout in your inbox for more information.
And Tina, I want to ask one more thing. Will and Dan, Kevin, you've been so fabulous today. There's so many more questions. One thing we've done in the past when we've got a lot of questions we haven't been able to get back to is we've held a subsequent gathering that just is Q&A. If we could find a time on your calendars, in the not too distant future, would you be up potentially for just doing some questions and answers with veterans, caregivers, and their families?
Absolutely. I think it's a great idea.
Most definitely.
Great. Kevin, that'd be great too.
Awesome.
Awesome. Tina, I just wanted to get that in before we concluded so that we could let folks know that the questions we didn't get to, we will.
Steve, that's great. And definitely not putting people on the spot there.
Yeah, right.
Great program. So we'll definitely get that information out to you as soon as it's scheduled. I want to thank everyone for attending, and I hope to see you all at the next Spotlight series.
Thank you.
Bye.
Good day.